lack of investment in public health care actually means that we have few hospitals, fewer doctors, and because of fewer hospitals and fewer doctors, it means reduced access to health care. Now, in practical terms, what it means is that the public hospital with a doctor is not very close to you, so you would have to travel long distance to get there.
कहाँ से हो आप? बिहार। किस लिए आए हैं? इलाज के लिए। अच्छा।
When you reach the public hospital, you have extremely long waiting times. Your turnover of patients per doctor is very high, so you meet your doctor for a very short period of times. There are roughly 700,000 doctors registered in India. But the shocking fact is less than 30,000 doctors work in the public sector. More than 30,000 doctors serve in the NHS who are of Indian origin. So you have more doctors serving the public health system of Britain than you have doctors of India serving the public health system in India.
क्या हुआ है?
ये फोड़ा है भाई।
फोड़ा है? अच्छा।
2 बार आए थे, मैं लौट गए थे, मेरे कोई सुनाई नहीं हुई।
अब क्या फिर कह रहे हैं?
अब कल सुबह 7 बजे की बोल रहे हैं। गाड़ी नहीं बन रहा है।
गाड़ी नहीं बन रहा है? क्या प्राइवेट में नहीं करा?
अब इतना हमारे पास पैसा ही नहीं है भाई, हम प्राइवेट कराते हैं।
सरकारी में आसानी से हो जाता है।
अब भाई हो जाता, अब हम पहली बार आए 2 बार तो मेरा
India provides a very interesting example of private medical care. On one side, you have globally competitive corporate hospitals, which in terms of quality can rival anything in Western Europe or America, and in terms of costs are perhaps 1/4 the cost. The unfortunate paradigm in India is that we cannot provide essential services for the poor, and the private sector is trying to provide services for Europe and the US, medical tourism. You have a situation with a very, very weak public sector and a very large, unregulated and active private sector. You will find places, especially where the poor live, where doctors without any kind of formal training have put up their clinic. So that's one part of the story. The second part of the story, even if you're a trained doctor, do you need any kind of permission? Do you need any kind of registration? Do you need to file in any kind of papers to set up a clinic? Actually, no.
नमस्ते डॉक्टर साहब।
हाँ जी, वेलकम। कोई नहीं, लो।
अच्छा, जनरल तबके, जनरल बीमारियों के लोग आते हैं
हाँ
ज़्यादातर।
जी, बिल्कुल।
तो बेसिकली जनरल फिजिशियन है आप?
हाँ, फिजिशियन सर्जन दोनों। छोटे मोटे जो बैंडेज ऐसे कोई घाव वाव लगते हैं तो कर लेते हैं।
घाव के लिए होता है ज़्यादा?
और क्या है।
अच्छा, वैसे जो बेसिकली जो डायग्नोज अभी आप करते हैं,
हाँ,
वो किस तरीके से करते हैं?
मीन्स जैसा पेशेंट वैसे डायग्नोस होता है ना।
अच्छा,
जैसे पेशेंट के ऊपर डायग्नोस होता है वैसे कैसे होगा को।
तो आप BMS हैं?
हाँ जी।
जो सरकार वर्कार वाले जो चेक करने वाले इंस्पेक्टर वगैरह आते हैं?
हमारा रजिस्ट्रेशन रहता है ना, चेक करने का रीज़न क्या है इसमें?
नहीं, जैसे आप चाइल्ड स्पेशलिस्ट और सर्जन लिखा है तो
कहाँ खाली सर्जन दिखाया मैंने,
चाइल्ड स्पेशलिस्ट भी लिखा है ना।
चाइल्ड स्पेशलिस्ट की चाइल्ड की जो डायग्नोस होता है वो डायग्नोस कर लेते हैं।
The kind of care that you can access depends on the amount of money you have available. You wouldn't go sometimes to the best or the highest quality of care because you don't simply have that much of money. What we call the quack doctors who are practicing Western medicine with absolutely no formal training in it, when they're treating simple ailments, may not be doing much harm. But the major problem with quack doctors perhaps is that they don't know the limit of their abilities. So they go in for some kinds of harmful therapy in many cases. The example that I would like to give is providing injection of oxytocin during childbirth. Studies have shown injection of oxytocin during childbirth by such quacks leads to various complications like ruptured uterus, which can cause death. They lead to much higher rates of hospitalization at delivery. They lead to much higher rates of infant death. You see, my primary concern, and I'll state the bottom line is, the poor should be able to receive the service they need at a cost they can afford. Now, if it's very poor, the service should be free. The important issue is how is that service reaching the poor? Is it reaching through the public system? Is it reaching through the private system? 30 years ago, we had the Alma Ata conference and a lot of euphoria about increased public health responsibility by the government. However, soon thereafter, international donors have been systematically reducing the government's spending in public health and emphasize on private sector participation. The government has provisions for private sector hospitals to receive some kind of subsidy. In the past, it has been waiving off duties and taxes on imported equipment. It has been providing land at very cheap costs. And the deal is that when a private hospital receives this kind of government support, they will in turn provide services, free services for the poor. Unfortunately, this is often not the case. One way that private services get around this provision is that they provide free services to government bureaucrats, and they show that care to be part of their free services. So private services, if you ask me, are finding ways to maximize their profit and not really interested in serving the poor. No regulation, no standardization, no accountability, that's what you have the private sector. So in the name of efficiency, what we have been promoting over the last few years is actually a kind of market anarchy.
इमरजेंसी में आके अल्ट्रासाउंड करवाइए, कुछ कहेगा तो हम जरूर करवाएंगे। वो हमसे पूछेंगे क्या रीजन है अल्ट्रासाउंड का, तो